Hello, everyone. So we are continuing the part two of surgical anatomy and physiology. And in the part one, we had studied these three topics. And in the part two, we will be continuing to learn about these three topics, in which, first of all, we will be learning about the fluid and electrolyte balance in the surgery. What is the importance of blood loss, transfusion, and volume replacement in the surgery? And what are the surgical considerations in the pediatric, geriatric, and obese patients? So, first of all, the fluid and electrolyte balance in the surgery. Now, before understanding what is the requirement, we must understand how the fluid in a body is basically present. So, the body fluid compartments are divided into two: intracellular fluid and extracellular fluid. Now, what is total body water in our body? So, the 60% of body weight is basically composed of water. So, total body water comprises of 60% of body weight. Now, what is intracellular fluid? Basically, it is the fluid inside the cells of body, and it is two-thirds of total body water. What is extracellular fluid? It is fluid outside the cells, and it includes the plasma and interstitial fluid, and it is one-third of the total body water. Now, again, the extracellular fluid is basically divided into two kind of fluids. One is interstitial fluid, that is three-fourths of the extracellular fluid, and one is intravascular fluid, that is the fluid in the plasma, and it is one-fourth of the extracellular fluid. Now, how our body basically responds to the fluid need. So whenever there's a need of fluid, the body starts to release the ADH, and ADH basically causes water retention. Also, body releases aldosterone. It causes the sodium retention, and also there's a release of cortisol. So all these hormones basically they promote the fluid conservation, but also they cause the maldistribution. So it is important to understand that our body, whenever there's hypovolemia or whenever there's a need of fluid, the body starts to release these three hormones, ADH, aldosterone, and cortisol. Now, this term is very important to understand that what is third spacing. Now, basically, third spacing is it is the pathological shift of effective ECF, both intravascular and interstitial, into a non-functional third space. So it is basically the shift of fluid from ECF into that space where you cannot use the fluid. Like it is bowel, lumen, it is interstitial space in traumatized tissue where the fluid will not be used in any function or any system of the body. So this fluid is effectively lost from the circulating system and does not contribute to the perfusion. So this was overall about the physiology of the fluid shifts. Now we come to the fluid management strategies and choices. Now you have to firstly understand what you have to give, when you have to give, and how much fluid you have to give. These are the important questions you must keep in your mind when you're giving the fluid. Now, before giving the fluid, you should assess the volume status. That if that person needs fluid or not. So, for assessing the volume status, you should see four things. The four Ds. You should see there is a decreased skin turgor, there is dry mucous membranes, there is decreased urine output, like less than 0.5 ml per kg per hour, and also there is diminished hemodynamics. Like the patient is having tachycardia or hypotension. If all these four signs are present, then you can give the fluid. Now, how you will give the fluid? There is 4:1 rule. It is maintenance versus replacement. A person always needs the maintenance fluid. It should always be given. But the replacement fluid is given whenever there is blood loss, whenever there is vomiting or diarrhea or any kind of third spacing. So this is 4:1 rule. Now, what you will be giving in the maintenance fluids? These are you have to replace the insensible plus urinary losses. Like maintenance fluids are always given because you have to maintain the fluid in the body. So you have to give 1.5 or 2.5 liter per day of hypotonic fluid. What kind of hypotonic fluid? Like dextrose 5% or 0.5% normal saline. These are hypotonic fluid which you should be giving in the maintenance period. Now, when you will be giving the replacement fluids, you have to give replacement fluids when there is blood loss, when there is vomiting, diarrhea, or third stress. So, in the replacement fluids, you should be giving isotonic, balanced crystalloids like lactated ringers, plasma lights. So these are isotonic fluids, and so you should give these fluids in the replacement fluids. Now, what are basically crystalloid choices when you will be giving these crystalloids? Like I told you, isotonic, in which you give normal saline, lactated ringer, plasma light. They basically stay in the ECF, extracellular fluid, and they are used for resuscitation. So whenever there is a need for resuscitation, you should be giving the normal saline or lactated ringer or the plasma line. These are the isotonic solutions. Hypotonic solutions like dextrose 5% water and 0.5% normal saline, they basically move into ICF, intracellular fluid, and they are used for maintenance and free water replacement. Right. So now you come to the hypertonic. These are 3% normal, 3% saline. Now, when you will be giving these hypertonic fluids, they will be used for severe hyponatremia or intracranial hypertension. Why? Because they pull water from ICF to ECF. So you have to use for hyponatremia and intracranial hypertension. So you have to understand these crystalloid choices when you have to give and where they basically go into ECF or ICF or where they are going. So when you are reading about the fluid and electrolyte balance in the surgery, now there are four common electrolyte imbalances which you will encounter. The one is hyponatremia, other is hypernatremia, and the next slide we will be learning about hypokalemia and hyperkalemia. So you have to understand what is hyponatremia, why it, what are the causes, what are symptoms, and how you will correct the hyponatremia. And same goes for hypernatremia. So hyponatremia is basically sodium less than 135 milliequivalents per liter. So how hyponatremia basically is caused? It is basically from most often from relative water excess. Whenever there's excess in body water, it causes hyponatremia. Like excessive hypotonic fluid administration, whenever you are giving to any patient, or there is a syndrome of inappropriate ADH secretion post-op, so it will cause more like water retention and the sodium in the body will be depleted. So how a patient of hyponatremia will present to you? The patient will be having nausea, headache, confusion, seizures, and coma. So for the correction, just remember one thing that you have to correct slowly. You don't have to give the sodium very fast because it can cause demyelination syndrome. So you have to correct slowly, and so how you are going to give? You have to give less than 6 to 8 milliequivalents per liter in 24 hours to avoid osmotic demyelination syndrome, and use hypertonic saline only for the severe symptomatic cases. Right. Now we come to the hypernatremia. Now, hypernatremia basically it is sodium greater than 145 milliequivalents per liter. What are the causes? Just think causes opposite to hyponatremia. Like whenever there is a water deficit, like inadequate free water intake, osmotic diuresis, or diabetes insipidus, these all will cause hypernatremia. So, how the patients of hypernatremia will present? The patient will be having thirst, lethargy, weakness, irritability, confusions, muscle twitching, and spasms. All these symptoms will lead you to the hypernatremia. So, how you are going to correct the hypernatremia? You must replace the water deficit first, orally, or with IV dextrose 5% water. And again, you have to correct it slowly to avoid cerebral edema because whenever you are giving too much fluid, there can be the risk of cerebral edema. So now we come to the hypokalemia and hyperkalemia. So hypokalemia is basically potassium less than 3.5, and it can be caused by diuretics. Whenever you are giving diuretics, GI losses, and any inadequate replacement. So again, symptoms are very important. How you will be diagnosing the hypokalemia? The patient will be having fatigue, weakness, especially in the legs, muscle cramps, spasms, constipation, paralysis, and rhabdomyolysis. Now, there are also risks with hypokalemia. There can be cardiac arrhythmias, there can be ileus and muscle weakness. So you have to avoid the hypokalemia. So how are you going to correct hypokalemia? You must be giving the IV replacement, that is maximum 10 milliequivalents per hour on monitor. Faster rates may require ICU. Also, oral is safer. So, whenever you are giving the potassium for hypokalemia, you must be giving at the maximum of 10 milliequivalents per hour. So now we come to the hyperkalemia, and it is potassium greater than 5. Now, what are the causes? The causes can be renal failure, tissue breakdown like rhabdomyolysis, and transfusion of old bloods or acidosis. So, what are the symptoms? How hyperkalemia will come to you? The patient will be having weakness, fatigue, numbness or tingling, nausea, muscle cramps. All these symptoms will be present there. So, what are the risks? The risk can be lethal cardiac arrhythmias, where you will uh, having the peak T waves in the ECG, or you will be having the widened QRS complex, and that can cause ventricular fibrillation. So, how you're going to correct for hyperkalemia, you must stabilize the heart state. So you must be giving the calcium gluconate, that is 1 gram IV over 10 minutes. Then you have to shift the potassium into cells, and you can do it in two ways. You can do it in the fast way. You can give insulin plus glucose, 10 units of regular insulin in the IV plus 1 ampule of dextrose, 50% IV. You can remove potassium from body. That is a slow process. You will be using diuretics if the kidneys are working fine. Potassium binders you can give like Caxalate or dialysis for severe or refractory cases. So now we come to the blood loss, transfusion, and volume replacement. Now you have to understand the physiology of the blood loss and how you will be assessing the patient who's having blood loss. So what is the body's response to hemorrhage? Basically, body tries to compensate that hemorrhage or blood loss. So pathophysiology for blood loss is basically whenever there's a blood loss, there's a direct loss of oxygen carrying capacity because RBCs are lost, and there's intravascular volume loss also. So then it basically results in the decreased preload, and it also causes the decreased cardiac output, and that decreased cardiac output again causes the decreased tissue perfusion and oxygen delivery. Now, what are stages of the hemorrhagic shock? That is ATNS classification. The class 1 is basically whenever there is a less than 15% blood volume loss, and it is usually compensated. The patient will be having normal BP, and he will be having a slight anxiety. But whenever you will be giving the fluid resuscitation, the patient will be uh, compensated, and it will be fine. So fluid resuscitation are often sufficient. In the class 2, there is the loss of 15 to 30% blood volume, and the patient will be having tachycardia, tachypnea, narrowed pulse pressure, anxiety. So crystalloid bolus are required in this class 2. In the class 3, there is 30 to 40% blood volume loss, and the patient will be having significant tachycardia, hypotension, confusion, and oliguria. So in this, you have to give the transfusion. And whenever there's class 4, there's the loss of 40%, greater than 40% blood volume, and the patient will be having profound shock, lethargy, absent peripheral pulses. So in this case, you have to give immediate transfusion, and the surgical control is often required. So how body compensates to this hemorrhagic loss? The body starts the catecholamine surge. It causes vasoconstriction and tachycardia. Fluid shifts from interstitium into the vasculature, that is auto-resuscitation. Now, the surgical response to blood loss. You have to control the source of the blood loss. Now, principles for the hemostatic surgery are you can control the source via any of these methods. You can apply the direct pressure. The first and most effective temporary measure is that you can ligate that artery. Suture ligation are clips for the individual vessels. Any vessel that is bleeding, you have to ligate that artery. You can use energy devices like electrocautery, ultrasonic shears, bipolar sealers for diffuse oozing in smaller vessels. You can use topical hemostats like thrombin-based powders or gels, fibrin sealants, oxidized cellulose for raw or oozing surfaces. So any of these methods you can do for hemostatic surgery. You can control the source or you can control the bleeding vessel. Now, this is important, the damage control surgery, DCS. Now, it is a life-saving strategy for the critically injured, and basically it abandon the definitive repair. Now, damage control surgery is basically for the critically injured patients, and it is basically performed in three phases. In the phase one, the surgeon does a rapid laparotomy to control the hemorrhage, like it packages or ligates the vessel, and contamination also controls the contamination. It staples or resets bowel, and there there's no anastomosis in this. So in the first phase, the surgeon does a laparotomy to control hemorrhage and to control contamination. In the phase two, the patient is shifted to ICU where he or she is resuscitated to correct the hypothermia, acidosis, and coagulopathy. These are very you say very dangerous signs. Whenever there's hypothermia, acidosis, or coagulopathy, you have to correct them in the ICU. So when all these things are corrected, the patient returns to the operating room for definitive surgery once the patient is stable. So damage control surgery is basically performed in these three phases. Now, now we come to the volume replacement. So in the volume replacement, we give crystalloids, spheroids, and what is the strategy? Now, for the fluid resuscitation, what are the choices and what are the consequences? Like in the choices, we have crystalloids, and in the crystalloids, we have balanced solutions like lactated bringers and plasma light. We have normal saline 0.9% sodium chloride, and how these are distributed in the body. Like in the balanced solutions, these are first line choices for any fluid resuscitation, and they basically have the electrolyte composition similar to plasma, and lactated vinegar has slight hypotonicity, so it must be avoided in severe traumatic brain injury. Like normal saline, it can cause hypercholeremic metabolic acidosis in large volumes whenever you are giving greater than 2 liter, and the distribution is basically only 25% of infused crystalloid remains in the intravascular space after 1 hour. So you have to remember this in your mind. After crystalloids, we have colloids. Now, in the colloids, we give albumin and hetastarch. These are larger molecules and theoretically better volume expanders than crystalloids. In the evidence, there's no proven mortality benefit over crystalloids. Starches can cause coagulopathy and renal injury, so these are not recommended for the routine. There's this 3:1 rule, the traditional but often excessive guideline suggesting that you should be giving 3 ml of crystalloid, uh, which will replace the 1 ml of blood loss. So whenever there's a 1 ml of blood loss, you should be giving 3 ml of crystalloid. Now, while you're doing the volume replacement, you should be avoiding the complications. You should be avoiding the pitfalls of the resuscitation. Now, whenever you're giving the resuscitation, you can be over resuscitating the patient. So you have to just bear in mind the complications. What can be the complications of over resuscitation? Tissue edema can happen. It will impair the wound healing and organ function. Pulmonary edema and ARDS are the common complications, and they will impair the gas exchange. Abdominal compartment syndrome (ACS), it can be complication of over resuscitation. It is basically elevated intra-abdominal pressure that is greater than 20 milligram of the Hg with new organ dysfunction. A surgical emergency is must for the decompressive laparotomy. Dilutional coagulopathy is again a complication of over resuscitation, the dilution of clotting factors and platelets. Now, what should be the endpoints of resuscitation? Additionally, there should be normalization of heart rate, blood pressure, and urine output should be greater than 0.5 ml per kg per hour. In the advanced, resolution of base deficits must be there, and lactate must be uh, in the normal quantity. These are the base indicators of restored tissue perfusion. And also, SVV optimization, mixed venous oxygen saturation. So these must be the things whenever you are giving the resuscitation, these must be normalized. Now we come to the transfusion, and in the transfusion, again in the transfusion, you have to start thinking what you are going to give, when you are going to give, and how much you are going to give. So, what are basically transfusion triggers? When are you going to transfuse the patient? First of all, hemoglobin is the important indicator. In the restrictive strategy, whenever there is a HB less than zero, you should be transfusing the patient. In the liberal strategy, whenever there is a HB less than 9 to 10, you can consider the transfusion, but for patients with active cardiac ischemia. So you have to remember these two strategies. In the restrictive strategy, HB less than 7 is safe for the most stable patient for transfusion. In the liberal strategy, HB less than 9 may be considered for patients with active cardiac ischemia. In the clinical context, whenever there is active ongoing bleeding, that is the ultimate trigger. You have to transfuse the patient whenever there is active or ongoing bleeding. So, or you are having the symptoms of anemia like dyspnea, fatigue, tachycardia. They are more important than absolute number in non-bleeding. Now, what you will be giving? What are the blood components? Commonly, we give packet RBCs for oxygen carrying capacity, like 1 unit of packed RBCs, they can increase HB by 1 gram per DL. Fresh frozen plasma you can give for coagulopathy, like elevated INR or reversal of anticoagulation. Platelets you can give for thrombocytopenia, like whenever platelets are less than 50,000 or there's platelet dysfunction. Precipitate you can give for hypofibrinogenemia, like whenever there's fibrinogen less than 150 to 200. So, what is basically massive transfusion protocol and what are the complications of massive transfusion protocol? Now, massive transfusion protocol is basically it is transfusion of greater than 10 units of baked RBCs in 24 hours, or it is basically giving greater than 4 units of RBC, packet RBCs in 1 hour, or replacement of greater than 1 blood volume. So, why we give massive transfusion protocol? Basically, it is a pre-established system-wide protocol for rapid delivery of blood products. So whenever there is a need of a rapid delivery of blood products, you basically give massive transfusion protocol. And it activates a 1:1:1 of packet RBCs, fresh frozen plasmas, and platelets. So it gives the equal amounts of all these blood products. And it includes the rapid access to cryoprecipitate and calcium. Now, what are common transfusion reactions that can happen? The patient can have a fever, so they can have febrile non-hemolytic like reaction. Most common that is benign. Allergic, like you say, urticaria can happen, itching can happen. Circulatory overload can also happen. There is pulmonary edema from volume overload. Acute lung injury is also a complication of transfusion reactions. That is non-cardiogenic pulmonary edema, and it can be fatal. Acute hemolytic reactions like ABO incompatibility, that is catastrophic, especially, and it presents with fever, pain, dark urine, and DIC. Now, what are the surgical considerations in pediatric, geriatric, and obese patients? First of all, we will come to the pediatric patients. Now, you have to firstly understand the physiology and pharmacological and requirements for the children or pediatric patients. So, this is the important light that child is not a small adult. So, there are key physiological differences. In the physiology, you see airway of the child. They have large occiput, so they have a neck flexion. They have a large tongue and narrowest at cricoid ring, not at the vocal cords. So uncurved ETTs are often used in young children. In the cardiac system, they have the high metabolic rate and high cardiac output. So stroke volume is fixed, but the cardiac output is heart rate dependent. So in these pediatric patients, bradycardia is an obvious sign of hypoxia. Whenever you see bradycardia, you see they can be having the hypoxia. Thermoregulation is very important, large surface area to volume ratio. So they have rapid heat loss. the mandatory active warming is required for the pediatric patients. That is forced air, warmed fluids, and increased room temperature. Blood volume is again very important, 80 to 90 ml per kg in the neonate, that is versus 70 ml per kg in the adult. So a 50 ml blood loss in a 5 kg infant is equivalent to 700 ml in a 70 kg adult. So you have to bear this in mind. Now, in the pharmacology, you see in the pediatric patients, their body composition is basically they have higher total body water and they have lower fat and muscle mass, and this basically causes the altered volume of distribution for the drugs. Hepatic and renal functions, they are immature until 1 to 2 years old, and they have prolonged drug half-lives whenever you're giving them morphine or benzodiazepines. Now, what are basically psychological and perioperative care you can do in the pediatric patients? So it is beyond physiology. The psychological aspects of pediatric surgery are very important. The psychological impact is that the patients will be having fear of separation from parents. They'll be having unfamiliar environment and the pain. So communication must be age appropriate. You must be using the use play therapy and clear and simple explanations. Parental involvement is very important. Parents are crucial partners in care. Keep them informed and involved where safe and appropriate. Their presence at induction is now standard in many centers. Managing parental anxiety is also a key part of managing the child. Now, how you will assess the pain in children? So, how then you have to manage the pain. First of all, you have to assess the pain using validated tools like we have Fleck scale for the pre-verbal children or patients and FACIT scale for the older children. And for the pain management, you should be using multi-modal approach like acetaminophen or NSAIDs you can give, plus regional anesthesia like caudal block, plus low-dose opioids. So you must be giving all these. But again, avoids opioid-related side effects like respiratory depression in the children. Now, what is basically FLAG scale? It stands for face, legs, activity, cry, and consolability. So it is basically age-appropriate tool for accurate pain evaluation in children. And it is used for pre-verbal in young children and approximately 2 months to 7 years, or though for those who are unable to communicate. So how it works, the clinician observes the child's behavior and scores each category from 0 to 2. So what is scoring in trained in this? The total score ranges from 0, that is patient will be having no pain, to 10, the patient will be having severe pain. So these are the categories, and then you can see the expressions in all these. Then you will be scoring according to them. Like a patient, you see their legs, if their legs in the normal position, you will be giving the 0 score, and the patient legs are uneasy and restless, you will be giving a score 1, and the patient is kicking or legs drawn up, you will be giving score 2. So this is how these scoring is basically done in the flex scheme. The FACES scale we call Wong-Becker scale. It is also used for the children approximately 3 years and up. So how it works, the child is basically shown a series of faces, and he or she is asked to point the one that best represents the pain. So there you see, if the patient or child points to 0, that means he's having no pain. If he or she points to 2, it means it hurts a little bit. If points to 4, this picture, the hurts a little more, you will be giving the score 4, hertz even more, this picture, so you'll be giving the score 6. So this is how so the clinician will be giving these faces or these pictures to children, and the children will be asked to point on any picture in which he or she feels right now, how much pain he or she is feeling. Now we come to the surgical considerations in geriatric patients. Now, before going to the geriatric patients, you must understand what is frailty syndrome and what is polyformis. So, you have to understand the aging physiology. Frailty is basically a clinical syndrome of decreased reserve and resistance to stressors. Now, how it manifests? It basically manifests as a weight loss, exhaustion, low physical activity, slow gait, and weak grip strength. So basically, the patient is basically has a some kind of exhaustion. The patient will be not having any kind of physical activity. Patient will be having problems in the gait. So it has basically uh, decreased resistance to the stressors. What is significance of this frailty syndrome? Frailty is a strong predictor for post-op complications and mortality than chronological age alone. So you have to understand this syndrome in the geriatric patient. Now, there is reduced physiological reserve also in the older geriatric patients. So, in these patients, cardiacally, you see decreased beta adrenergic response. So, they have the inability to mount a tachycardic response to hypotension. So, normal vital signs can be misleading because they have again the decreased beta adrenergic response. In the renal, they have decreased GFR and they will be having the increased risk of drug toxicity like opioids, antibiotics, and electrolyte imbalances. In the pulmonary, they'll be having decreased chest wall compliance, reduced cuff strength, and they'll be having the higher risk of atelectasis and pneumonia. Polypharmacy is important to understand. They have higher risk of drug-to-drug interactions and adverse events. Like you have to review the pre-op medications like anticoagulation, coagulants, antiplatelets, that they can be having the bleeding risk. Beta blockers, they can cause bradycardia, diuretics like electrolyte shifts and dehydration, and also hypoglycemics. Now, there are some unique post-operative challenges in the elderly patients. Common and serious complications in the geriatric patients are basically one of the most common is delirium. So delirium is a serious sudden disturbance in a patient's mental ability. Now, what happens in this? It results in a confused thinking. The patient will be having confused thinking, reduced awareness of the environment, and a decreased ability to focus, sustain, or shift attention. The most common post-op complication is in the geriatric patient is basically delirium, and it is precipitated by infection, drugs, electrolyte imbalances, and sleep deprivation. Now, what will happen? Can happen is that the patient will be having functional decline, loss of independence is a major trait after any kind of surgery. Early mobilization is critical in these patients. They can be having failure to thrive, often multifactorial, that is anorexia, depression, or pain. Atypical presentation of disease like MI may present as delirium, and infection may be present without. So these are all important post-op complications in the geriatric patient. Now, what are the goals of care and shared decision making? The risk or benefit ratio of surgery can be vastly different. So you must discuss with the patients and you must be going like a patient centric goal. So you must be asking the patient in the geriatric patient what is most important to you. Either you want independence, you want the pain relief, or you want survival. So all these discussions must be held with the patient. Palliative care consultation should be integrated early for major procedures, not just at the end of life. Now we come to the surgical considerations in obese patients. So, what is basically the impact of obesity on surgical planning and technique? And the pathophysiological, the obesity can cause pathophysiological changes. Like in the cardiopulmonary, you see they have the high oxygen demand, they have low functional residual capacity, and it basically causes rapid desaturation during apnea. They best in obese patients, there is a high prevalence of OCA, obstructive sleep apnea, and obesity hypoventilation syndrome. In the obese patient, coagulability, the issues of coagulability, chronic inflammatory state, they can increase the risk of venous thromboembolisms. In the pharmacology, you see they have the increased volume of distribution of fat-soluble drugs and altered clearance. Again, it causes unpredictable dosing. Now, what are technical surgical challenges in the obese patient? First of all, access is very difficult. They have thick abdominal wall and it requires longer instruments and retractors. Exposure again is very challenging. Intra-abdominal and visceral fat can obscure the anatomy in the obese patients. Tissue handling again is very much challenging. Fat is friable and it holds sutures very poorly and is poorly vascularized also. So they have the increased risk of seroma, infection, and bone lesions. Now, how you are going to optimize the outcomes in bariatric and non-bariatric surgeries? So, what are the anesthetic considerations? They have if they have difficult airway is a known risk for the obese patients. So they have a difficult airway. You should be having a difficult airway cot available, and you should be positioning the patient into the head elevated laryngoscopy position or rammed position to align ear with the sternum. In the ventilation, you should be using higher PP positive and expiratory pressure to prevent atelectasis. In the laparoscopy and pneumoperitoneum again can cause different complications and you often necessary for improved exposure and recovery. So you have to do the laparoscopy and you have to avoid the pneumoperitoneum. In the cardiopulmonary system, Trundle-Ledberg position plus pneumoperitoneum, they significantly increase airway pressures and they reduce the cardiac payload. So close communication with the anesthesia is vital. Now, how you can basically prevent the complications? Like in the wound complications, you should be having the meticulous closure, consider subcutaneous drains to eliminate dead space, uh, to avoid the venous thromboembolism, you should be using aggressive weight-based chromoprophylaxis, and early and frequent ambulation is also advised. For the drug dosing, you should be use ideal body weight or lean body weight for dosing water-soluble drugs like antibiotics, and use total body weight for weight-based low molecular weight heparins. So whenever you are giving antibiotics, use the ideal body weight or lean body weight. And whenever you are giving the low molecular weight heparin, you should use the total body weight. So this was all about our second part of the surgical anatomy and physiology. Now we come to the clinical scenarios related to the what we have learned in today's lecture. So clinical scenario one basically is a 55-year-old male is undergoing an elective open right hemicolectomy. After 2 hours of surgery, the anesthesiologist notes a metabolic acidosis on the arterial blood case. The surgeon has been replacing blood loss primarily with 0.9% normal saline. Story. Which of the following is the most likely explanation for this finding? So, how metabolic acidosis has developed in this patient who is having the 0% 9% normal saline? So, it is due to hypercholeremic metabolic acidosis. A 45-year-old man with a perforated peptic ulcer undergoes an emergent laparotomy. During resuscitation, the surgical team aims to replace the third space process, into which compartment is fluid primarily restricted in this phenomenon. So, what is third spacing? Basically, it is fluid in those areas where it cannot be, like you say, used in the perfusion. So, it is non-functional extracellular space, that is bowel wall or interstitial spaces. The surgical team is managing a patient with a serum potassium level of 6.8 following a ruptured abdominal aortic aneurysm repair. Which of the following is the most appropriate first step in the management? So, whenever there is a hyperkalemia, you must be using immediately which compound? You should be administering the IV calcium gluconate. A 25-year-old male arrives at the trauma bay after a motorcycle crash. He's tachycardic to 130 beats per minute, but has a normal blood pressure. His focal assessment with sonography for trauma fast exam is positive for intraperitoneal fluid. Which of the following class of hemorrhagic shock in this patient is most likely? So patient is basically tachycardic, but the blood pressure is normal, and there is no much there are no other signs of symptoms of shock. So it must be a class 2. What is the primary goal of damage control surgery during the initial laparotomy for a severely injured trauma patient? So there are three phases of DCS surgery. So first of all, what you're going to do in the first phase, you should be controlling the hemorrhage and controlling the contamination. A 85-year-old frail woman with a history of dementia is admitted for a hip pinning after a fall. On post-operative day 2, she becomes agitated and confused. Which of the following is the most appropriate first step in the management? So, in the geriatric patient, the most common side effect is most common complication is delirium. So, for the delirium can be due to any infection. So, first of all, you have to see any infection. So, you have to check a urinalysis. When calculating the dose of a low molecular weight heparin for VTE prophylaxis in a morbidly obese patient, which weight should be used? So for low molecular weight heparin, should be using total body weight. So these are the references from which I have taken the text and also the references for images. And this was all about the part two of surgical anatomy and physiology. Thank you so much.